Although we have worked for more than 10 years on MRD in our research setting, not until quite recently people started to realize in the clinical setting that this actually is something that maybe should be used in the clinic every day. And I think it's driven by two major factors. One is the fact that the new therapies are so much better, so patients can very likely obtain a complete response. So many patients have no detectable disease with the old standard technologies with protein electrophoresis and immunofixation tests. So it's really time to go beyond that and look deeper. The other reason, the other mechanism is really the access to these assays that can capture minimal residual disease. For a long time, people have tried different ways. They have tried PCR-based assays. They have tried flow cytometry. The early attempts were done in an era when the drugs were very inferior, so no one really paid attention. The technologies have continued to improve, and now we have flow cytometry assays. The best ones can detect about one cell in 100,000. So it's a matter of having a combination of 10 antibodies that have been defined in consortia with the National Cancer Institute and others, and here in Europe with the Euroflow consortium. And using these assays with a sufficient amount of cells, the number of events that you need to investigate, you can, by these definitions, declare MRD negativity. If you don't find any cells that have any of these features by these assays, and you capture the correct amount of events, you can truly say this is an MRD negative patient. Now, there has been further work on the PCR-based assays, so we have the next generation sequencing assays that basically are combinations of many primers that could technically occur in different patients across the board. So having assays that include many primers, you can use the same platform and take a sample from any person and run on this platform. And you will have some primers that would anneal, that would work and give you the results. So the benefit with these assays is that they are more standardized and also they're more sensitive. I mentioned before that if you have one cell in 100,000, 10 to minus 5, or you can find one cell in a million, 10 to minus 6. If you use those types of assays, the less good and the better one, there's a difference in the progression-free survival for those patients that actually are negative with these assays. So I'm quite convinced that the 10 to minus 6 is going to become the new standard, and that's how we have to do it. So that means that we are moving away from flow cytometry into sequencing. And I think here at EHA and also from ASCO that happened last week in Chicago, there were very many presentations that all were based on the sequencing-based assays. So what are the next pieces that we are missing? Well, I do think that we need to have these assays readily available, and that's coming. In the United States, I think within 2 months or so, the FDA is anticipated to approve next-generation sequencing-based assay for MRD testing in the hematologic space. You can already now purchase assays and set it up, but it's a little bit cumbersome to do that. Once the FDA has approved it, I think the field will move very fast, and we will see that more and more doctors are going to use MRD-guided treatment.